contribute to the fabric of our neighborhoods and larger communities. The infrastructure of Minnesota Community Pharmacy has been crumbling for the past decade, and we've reached a breaking point. Chronic low and under-cost reimbursement for pharmacy services has resulted in hundreds of pharmacies in Minnesota closing over the past 10 years. To illustrate what I mean by that, I brought with me what I call the stack. They say, well, what is the stack? The stack is a report of all the prescriptions we filled at my pharmacy in 2024 at or below our operational cost. The worst being on line number 1, the last page is where we finally break even. There's 55 lines on a page, 754 pages. If you do the math, it's a little north of 41,400 prescriptions. This is 65% of my business. We had to go this deep into it before we got the actual cost of the drug back. At this point, we have enough revenue, not profit per claim, but revenue per claim to buy a candy bar. We're talking about prescription drugs and professional services here. Here's where we reach enough revenue to buy a typical cup of coffee at a shop. The craziest thing about this took 5 full-time equivalents, 2 pharmacists, 3 technicians, 8 months to produce this body of work, all at a loss. While mine is 65%, I've talked to some of my colleagues and around the state, and some are in the 70% of their business is below operational costs. And that cost is defined by state statute in Minnesota here. So the legislature proposed would provide a short-term fix and then a long-term fix. The short-term fix would get us to implementation day of January 1, 2027 of the longer-term fix, which Andrew Russell, a pharmacist colleague of mine, will explain a little bit more. Deb Kevaney, kind of our spearhead leader of our Minnesota Independent Pharmacists group, would love to have been here today. She's down in Winstead, holding down the fort on Main Street, keeping the pharmacy open and serving patients. So she sends her wishes for this to actually come to fruition and get this done. So with that, I'll leave you with Andrew Russell of Elko New Market Family Pharmacy.
Thanks, Sean, and thank you, everybody. My name is Andrew Russell. I am the co-owner of Elko New Market Family Pharmacy, a small independent pharmacy located in Elko New Market, just south of the Twin Cities Metro. I'm here today representing Minnesota Independent Pharmacists. I'm here today to say that patient access starts with an open pharmacy. Pharmacies throughout Minnesota have been closing at an alarming rate. Over the past 10 years, around 44% of Minnesota pharmacies have closed their doors. 58% of these were independent or non-chain pharmacies. In the last 2 years alone, 40 pharmacies have closed their doors. 8 smaller cities in Minnesota have lost their only pharmacy. And they're closing everywhere, not just rural areas. Urban areas are affected as well. The Minnesota Department of Health estimates that more than 1/3 of residents in Minneapolis, St. Paul, and the first-rank suburbs are now living in a pharmacy desert, or an area with critically low or no access to pharmacy care. In a 2024 study, Minnesota ranked 10th in the nation for the largest proportion of residents living in a pharmacy desert. Minnesota Independent Pharmacists applaud the bipartisan work of our legislature this session and urge swift action to address what is widely regarded as the primary driver of pharmacy closures throughout the nation: unsustainable under-reimbursement by pharmacy benefit managers, or PBMs. In this case, the PBMs contracted to administer medical assistance outpatient drug program, which accounts for roughly 85% of the 1.2 million Minnesotans covered by MA. The bipartisan framework taking shape this session includes 2 essential provisions. The first, the short-term solution that John mentioned, a directed dispensing reimbursement to qualifying rural, underserved, or independently owned pharmacies to preserve prescription access and improve health outcomes for our medical assistance patients. The second proposal is a transition from the MA prescription drug program to a single pharmacy benefits administration model. This provision will save Minnesota taxpayers a considerable amount of money by establishing a more accurate and transparent drug pricing index, by reducing duplicative administration spending, and end certain abusive tactics used by PBMs, such as spread pricing and network steering. This provision will also have greater drug transparency, and ensure reasonable reimbursement for pharmacies in order to maintain pharmacy access for Minnesota's most vulnerable patients. The single pharmacy administration model will build on the experience of other states who have successfully implemented similar programs, and this demonstrates two very important things: that pharmacies can be reimbursed fairly and at the same time save significant taxpayer dollars. These proposals are a win for both sides of the aisle, patients, communities, and pharmacies alike. Again, patient access starts with an open pharmacy. The provisions proposed here are smart, bipartisan solution that puts patients and communities first. We are grateful to the legislative leaders on both sides of the aisle for coming together to understand the challenges facing our community pharmacies in Minnesota and acting to protect Minnesota's most vulnerable patients. These proposals are a vital lifeline for Minnesota's independent pharmacies and the patients we serve. Thank you. Let's get this done.
Questions?
Can someone speak to, I remember, I think it was last year that you guys were here talking about the reimbursement rates and not matching the cost. Did those go up? Maybe it was 2 years ago. Did those increase, and have you seen any impact of that? Like any legislative changes that you called for in the last 2 years, and how that impacted anything that you've done?
Yeah, so last year, the dispensing fee for medical assistance was raised from $10.70 to $11.55, so $11.55 is where it sits today. However, that, as Andrew had talked about, 85% of the medical assistance claims in Minnesota are administered through the managed care organizations and their contracted PBMs. And so that $11.55 fee really only affects 15% of the medical assistance claims in Minnesota that are paid for through the fee-for-service system at the state level. So the fee we're collecting or getting in place of $11.55 from the 85% that are administered through managed care organizations and their PBMs is anywhere between 0 and 25 cents. So it's a far cry from $11.55, which is what the state has determined it costs to put a script together and get it to the patient in a safe, effective manner.
So, just want to check on the status of these proposals in the legislation. I don't know where I saw it, but I think I saw that they're in the omnibus bill.
They're in the omnibus bill in both bodies.
Okay.
So,
In the health, which
Health finance
Health
in
finance.
both bodies.
Yeah, it was was passed on Monday, and the Senate's going to take it up today. So, and it's in both bills.
So I'm assuming hopeful that it's gonna go through today, right?
We are hopeful, yes. But in the past, we've had things on the line, both federally and at the state, where last minute things have changed, but we're here to say we need this, or we're really gonna be in a dire situation. You know, this can't continue. You know, this is 65% of our business. It can't continue.
Someone speak to how Medicaid cuts potentially coming in federally could affect what's going on in the state level?
Yeah, I mean, until we get a clear picture of what that looks like, and certainly the cuts they're talking about are definitely going to affect things, which means that we need to get smarter with the way we spend state dollars. And the system we're operating right now, where 85% of it is done through the managed care organizations and their PBMs. I mean, we're really throwing a lot of money at them, and we're not getting back what we're spending. So bringing it into a single pharmacy benefit administrator model will save the state a ton of money. So these are important changes to be able to bridge what's potentially coming from the federal level.
Is merging it into this single benefit model eliminate the PBMs, or is it just create one PBM?
Well, currently, with the different managed care organizations in Minnesota that administer medical assistance, there are 7 different PBMs that are being paid by the various managed care organizations. So what this does, and 7 different rates and 7 different entities and 7, there's just all this duplicative administrative burden. So what this does is it brings all of that into one. And so the state would contract with one. The managed care organizations would then need to contract with that one. And so it just really streamlines everything and controls costs, controls all of the ways that money is sliding out of the system right now as something other than care.
And if you're streamlining it into one, I think that gets at the problem of what you're saying about the PBMs driving down the margins with the low reimbursement rates, because all of them would want to, make money off of this. If it's going to one place, it's easier to control, isn't that it?
Right, and it makes certain that the pharmacy, all of us, get paid appropriately. Get the $11.55 that the state has determined it is required to be able to provide services in Minnesota.
The state sets the levels instead of the PBMs that are.
Right, which you'd see more of that increased rate that you talked about, that you're not.
Yeah, instead of it being applied to 15% of the Medicaid population, it would be applied to 100% of the Medicaid population.
Then, and this perhaps is a silly question, but it seems simple enough, right, to do that, or that you could have done that years ago, not had 7 PBMs. Why has it taken this long, or why has it been until now that?
Well, I mean, some things, get, as long as things are rolling along, they get left alone. It's like the PBMs don't want this, the MCOs don't want this. So that's a big hill for us to push up against. And finally, I think we're at the breaking point where it's like we decided a year ago that we had to do something or we were all going to be gone and leaving patients without access to pharmacy services. So we got serious about it, and here we are today, due to a lot of effort from this whole group here.
But it sounds like it doesn't come at by doing this, it doesn't come at an additional cost to the state when they're, being very picky about their budgetary items
Right.
this
It
year.
actually saves the state money.
I have another question if nobody else has one. How much is out of the state's control? That is, the federal government needs to do something with the way it approaches rates, and the state kind of can only do so much.
Yes, and you're correct that this is not all medical assistance. This is commercial, this is Medicare, this is medical assistance. The state can control medical assistance. And so that's really what these provisions are talking about, the medical assistance population, which is part of our businesses, right? None of us here serve 100% medical assistance patients. Now, at the federal level, that's where Medicare has to get addressed, because we're getting the same, below cost reimbursement from those plans as well. And also, the commercial plans need to be addressed because they're being operated. And really, at the end of the day, the 3 big PBMs in the country control over 80% of the prescriptions, whether they're Medicaid, Medicare, commercial, self-insureds. They're all running through the same systems, and so they're paying us based on the same rates. And so federally, we need to do some changes, but right now we're working on what we can do in Minnesota to start heading in a better direction, at least with the Medicaid population.
Could you speak to the unique situation that this is in, that there's a business or profession that is being reimbursed, told how much to be paid, regardless of how much that service costs? That seems pretty unique in the world of business. I can only think of a handful of businesses or industries that are approached that way.
Yeah, so this is not new. This has been going on. I've been a pharmacist for 35 years. This has been going on for 35 years. And so it has just gotten egregiously worse over that time to where we are today in the present. And part of it really goes back to what I just said a few minutes ago, that 3 pharmacy benefit managers control 80% of the prescriptions in this country. And so whether you work for this company or that company or that company, is a strong likelihood that your pharmacy benefit is administered through one of those 3. And basically, and they know it. They know they have that much power and control. So they offer us a contract that says, here's what we're willing to pay you. And we say, well, we'd like to negotiate a better price. And they say, we don't care, we don't negotiate. And so we end up either saying no to that contract and taking that part of our patient population and just wiping it off of our service, platform, or we say yes and try and make it up by some other means, some other product selection, some other service, some other this, some other that, some niche thing that we do, whether it's compounding or vaccinations or something. We make money where we can to fill in where we're losing money on these contracts. Now, 20 years ago, it was possible to do that. You could literally make up the losses. Today you can't. They're just too great and too much of the total percentage of your business to be able to make it up by some other means.
If I could interject for a second, too.
Yeah, go for it.
We're also talking about with these PBMs, they also own pharmacies too. So we're in the unique situation where we have to sign contracts with companies that are our direct competitors. So our direct competitors are setting the rates that we get reimbursed at. That's not fair for us smaller pharmacies, and it's certainly not a sustainable way for the healthcare system to work.
Further questions? We're good, thank you. So I did mention it, that TV or anybody wants to do extra footage or shots at St. Paul Corner Drug, it's on 94 in Snelling, kind of by McAllister, that we do that. We call on my phone number on the sheet. Good? Or do you want it one-on-one interview? You can let me know too. Cool? Thank you. Yeah, thanks, Carol.
Thank you.
Thank you for being here.
Yeah.
Thank you.